Before we get started, I just want to make a couple of um, logistical remarks. This webinar series is funded by a generous donation from a family who's been affected by BPD. And so I think they understand the struggles that so many of you are dealing with. And we at McLean Hospital are really hoping to be able to lend our expertise to help all of you. So please join us on a regular basis. We'll be having these webinars once a month. We might have them even more frequently in future years. And we're archiving and recording all of these webinars. They'll be posted on our website. If you don't know where our website is, it's right on the screen in front of you. If you look at the McLean Hospital logo way up on top in the upper left-hand corner, if you click on that, you'll get right to our website. You might want to do that now and save that as a favorite location, and then you can come back to that in the future. Additionally, we've got another webinar scheduled already for January 4th. Dr. John Gunderson is going to be speaking with us. For those of you who don't know him, he's a professor of psychiatry at Harvard Medical School, and he really was instrumental in helping to define and refine the diagnosis of borderline personality disorder using empirical data to tell us more about the disorder, and has really devoted his entire career to working with patients and families affected by borderline personality disorder. So we hope you can join us for the January 4th webinar. If you want to register for that now, you can download the flyer by just clicking on it. It's down at the bottom of your screen, and you'll be able to register at any time. So tonight's webinar features Maureen Smith, who is Director of Family Services in our Gunderson outpatient program. She has devoted her career to really working with families and patients affected by borderline personality disorder, has decades of experience with this. And we are delighted that she has agreed to come today to speak with us on family struggles and common challenges. She's got just a few introductory slides to orient you to some common issues, but really the bulk of this webinar is going to be spent addressing your questions, your concerns. So we are going to rely heavily on you to kind of fill the content of tonight's webinar. So we hope you have come with some questions. They don't have to be related to anything at all, as long as they're, I guess, related to borderline personality disorder. We welcome them. So if you have come to this webinar with a question, and you already know what it is, please type it in. There's a Q&A box in your lower right-hand corner. Type away. We will get to as many of them as we can. I want to let you know that in order to maintain your confidentiality, other participants can't see your email, they can't see your name. All of your microphones have been muted, so nobody will be able to hear you. So the only way for you to interact with us is by typing in that Q&A box. So please type away. And now it's my pleasure to welcome Maureen Smith to the webcam, and Maureen will take it away.
So we're all set. Let me get my... Hello, everyone. It's very exciting to be here today to be able to have this kind of a format to reach out to, the many people across the miles that deal with borderline personality disorder. So I want to just say that my work, primarily I work with parents who have young adults with borderline personality disorder. But in addition, I also have a lot of contact with people who are parents with BPD or a sibling. Everything that I'm going to be talking about, and I just want to do a sort of a broad brush of the kinds of questions and issues that come my way, are really applicable to anyone with BPD. So just want to make that clear. And as Dr. Palmer mentioned, we welcome all your questions. We really want this to be an interactive experience. So I may need to use my glasses to do my slides. So here we go. So I'm going to talk about a few family struggles here. And these are not exactly in order of importance, but they do, these are sort of the big ones. The first is that in a family system, there's often a lot of chaos. The famous book that people refer to is called, and I try to emphasize, it's Stop Walking on Eggshells, because people do tend to find that the level of reactivity and high emotion with people with BPD creates a lot of difficulty. You see it particularly around the holidays because celebrations, family celebrations can be very tricky and often triggers for people with BPD. So it's not unusual that this can be a difficult time of year. And it goes along that when there's high conflict, it's very challenging to be an effective communicator. So communication skills, and we're going to talk a lot today about skills because how you interact with the person you love who has BPD can be a great influence and a huge factor. So really understanding and thinking about how one communicates can be a very important focus. Treatment becomes quite an issue, especially if you have a family member who doesn't admit to their problems, doesn't see that it has anything to do with them, and often is refusing to either go into treatment or therapy or that sort of thing. And they can also be somebody who has BPD and is in an individual therapy, but there's no contact with the family at all. And family members often say, I can't imagine what this therapist thinks of our family because, the person is so negative often about family situations. So either there's no treater or there's a treater that's not having any contact with getting input from the family system. Now, these are sort of the safety concerns, which I put down are kind of in opposite order of importance. Suicidality is probably the symptom of BPD that is most troublesome to family members, obviously. Then there are self-harming behaviors such as cutting, substance abuse, and in general, risky behavior. These are very stressful for families and very frightening in terms of how to properly kind of react to them. So these are, put a lot of high octane into family situations. And I guess the last one I put down there is sort of misinformation about BPD and a lack of resources. And I hope today that at the end of the talk, I want to make sure we go over. There are some very good resources for information and for support because understanding borderline personality disorder is very, very important if you're dealing with somebody who suffers from it. And a little plug for the first webinar that Dr. Lois Joy Kane did, which is on borderline personality disorder. And it's a very comprehensive overview of the disorder and very well done. So just want to recommend that. So when treatment is possible, I wanted to speak to this because a lot of family members get very focused on if I can just get my family member into treatment, then things will be so much better. So I wanted to point out that there's some things that treatment can do, and there's some things that it really can't. So just starting, one of the best things about getting somebody seen by a clinician is to get a good diagnosis. And this is something that comes up all the time, that people with BPD are diagnosed with other mood disorders such as depression or anxiety, but the personality disorder is not diagnosed. So that they're treated for the mood disorder and the personality disorder is not understood or recognized, or if it is recognized, it's not really acknowledged. And I think we know through a lot of John Gunderson's work and others that treating the personality disorder is kind of treating the engine of the mood disorder. So while there's obviously lots of complication in this, it's a broad brush that if you're not attending to the personality disorder, troubles will continue. And I wanted to touch on what reasonable treatment goals are, especially considering the complexity of BPD. And I've noticed that a lot of families, they get their family member into treatment and they expect more. They expect people to feel better. Actually, what often happens is that somebody gets into treatment and they feel worse. They're kind of sad at their situation, understandably. So there's also some very reasonable goals that people should expect, and that would be a decrease in symptoms, especially the self-destructive symptoms. And most of the empirically based programs we have target suicidality, self-harm, high risk, and that is the first thing that is focused on. But I think people are often unprepared for how difficult treatment can be. I thought I'd throw this in because it's so confusing to people. What's the best treatment? And cognitive behavior therapy, dialectical behavior therapy, mentalization-based treatment, transference-focused treatment, STEPS, which is, I had to actually write this out because I forgot it, strategies and tools to enhance performance and patient safety. We always refer to it as STEPS. But these are manualized treatments, and the reason they're so important is that it provides a standard of care and a standard of treatment that can be practiced by many people, and that there's a quality control to it. And DBT does not work for everybody. It's the most well-known treatment, and it is highly effective. But I often want to stress the fact that treatment all kinds of treatment can be helpful, and there's some, a basic treatment alliance is probably the most important thing. And then I wanted to put this in terms of treatment for family members, including psychoed, like what we're doing today, and skill building can really make a difference. So even if you have a family member who refuses all treatment, you're doing things like this, doing webinars, and maybe taking advantage of some of the other resources we're going to talk about, can really, really make a difference, and that has been proven. And so I have here, what can families do and become interpersonally skillful, and that's something that we'll probably talk about today related to the questions that come in. And I wanted to sort of highlight a few skills that I think we'll be touching on. Validate emotions and feelings. This is not about what's factual. People talk a lot about validation in dialectical behavior therapy. There is a term called the invalidating environment that is very hurtful to families and parents. But if taken in the right context, learning how to validate somebody who's highly emotional, who may have a lot of reactions that don't make a lot of sense, how do you kind of say to that person, I see you're suffering, rather than, I can't believe you're upset over, your boyfriend not calling you tonight. How do you sort of understand that recognize their emotion and not be judgmental about whether it's too big a reaction or that sort of thing. So I have a sense that we'll be getting back to that skill. Practice mindfulness. Don't go with the drama. There's a lot of drama. That may be a judgment, but there's a lot of high action, a lot of high emotion in this disorder and in a family system. And mindfulness, which Dr. Blaise Aguirre talked about in our webinar last month, which is another great one that's archived to look to, is a skill for both patients and for family members. And it's because there's a high level of conflict and stress that learning how to slow things down and be mindful is a very important skill. And this next, managing reactivity, really connects with mindfulness. But this recognizing how reactive patients are and how easy it is to be reactive to them, you always want to try to slow things down. And, sometimes people will say, well, my daughter called and she presented this crisis on the phone and I was in the middle of a meeting. And I didn't know what to say, and always buying time, always saying, I need to think about this, I will get back to you in a half an hour, whatever the strategy is, to not start to fuel a lot of escalation. I put this in because I think it's so important about being authentic. People with borderline personality disorder tend to be very, very sensitive, interpersonally sensitive, which also makes them very aware of insincerity. And this is a challenging one because you can often feel angry with people with BPD. So one of the things about becoming skillful is to be able to own what you're feeling, but in a way that is without judgment and without, sort of a negative stance. And that takes a lot of practice. And I want to sort of underscore the fact that all of these, being interpersonally skillful is something we work on throughout our entire life. And then the last is sort of a really simple, but it's modeling behavior. If you, you really can, bottom line, treat your family member the way you want to be treated and point that out. I'm trying to listen to you. I'm trying to be really mindfully listening to you. And it's very important for me that you also can hear me out, but you have to be able to do the behaviors that you're looking for the person to do as well. I wanted to put in a few things about what's not possible, although I feel this may come up with some of the questions. And I had to just throw these out. You can't make somebody go into treatment. You can't make them get a job. You can't even make them clean their room. And often parents and family members are looking for the expert to tell the person not to do X, Y, or Z, or to do X, Y, or Z. And it really isn't, that's not the way it works. And what we want to do today is to try to think about how to work with people who have behaviors that are problematic. And that's quite a challenge. What is possible is, and this is kind of the crux of how this is done, is, and it's very hard to do, but create a collaborative environment that involves contingencies and incentives. There are a lot of contingencies in DBT, like if you do this, this is the way it is. And I just listed a few, but things I found over time is that it actually, if you have somebody who's refusing treatment, it actually is useful often to do the research to find out if there are people who are skilled in DBT or in borderline personality disorder. And again, we can look at the resources later about how you might find somebody with that expertise. And be able to have, if your family member is open to it, to say, well, I have some things for you to look into if you'd like to. So you can do some research. There's also creating reasonable contingencies that a lot of the people I work with have adult kids who are living at home. And if they're living at home and there are certain things you can say, I can do this for you, and this is something I need you to do. Again, it sounds simple, it's pretty complicated. And certainly on a case-by-case basis is how we work this out. And also creating incentives. If you get a job, we'll match your salary. Well, it's usually not that simple, but people have often given incentives like, if you get a job, I will, give you a certain amount to, incentivize the job. Because many jobs that people with BPD may need to do is a recovery job, which doesn't really earn a lot of money and can be very challenging for them. So you want to try to make it worth their while. So I think that's it. These family guidelines, I'm hoping that we can refer to as we pick up some questions. So I don't know if we have anything in yet.
We have a lot of great questions for
Okay.
you, Maureen. A couple of people have already asked the same question.
Okay.
So a couple of people are struggling with an adult child who refuses treatment, either doesn't believe she has BPD or just doesn't want to get treatment. And how can family members be helpful, and how do you see where do you see their role?
Mm. It's such a good question, and it's so common, and I think the term that comes to mind is a light touch, because I hear young adults saying all the time they come into treatment and like, my mother can go into DBT if she wants to, but I don't want to do DBT. So that there's a way in which if you push an agenda too hard, it is a lost cause, and you will actually kind of poison the well, so to speak. So I think that idea that somebody with BPD, if you think they have it, if you've looked at the criteria and it seems to make sense, I want to say this, that in our experience with young adults in our program, because there's a less stigma in the younger generation, there certainly has been stigma in the past for BPD. So there could be people who would say, I don't want that diagnosis. That's a terrible diagnosis to have. Well, what we do know now that, as Mary Zannarini would say, it's the good prognosis diagnosis. We know that there is treatment for BPD. People get better. So of course you want to promote treatment. So the idea that you could potentially get some information for them to look at. Saying, I think you have BPD is going to be labeling somebody that is going to generally get somebody's hackles up. So remembering the collaborative approach, saying something like, I read about this, and when I looked at it, and there's a lot of good material like the BPD brief, which I'm going to make sure that people take a look at. I've read this, and it seems to make such sense to me, and it seems to capture some of the things that you struggle with. If you have, I would love for you to take a look at it and let me know what you think. That's much better than saying you have borderline personality disorder. No one likes to be told that they have a label, because it can feel like a label. Our experience with people, young adults, as I started to say before, is that there is not the same amount of stigma. There's often great relief in saying, oh, this is an understandable diagnosis. People know about this. I'm not alone in these feelings, because the kinds of what somebody with BPD suffers with is a very isolating, alone, high emotional kind of state. And when they recognize that we know what this is understandable, this is, there's a lot of literature on it, and of course you want to get the right literature I want all of you folks out there to have the right literature. I wouldn't give a book to somebody. I would say, I would use the BPD brief or something like that and say, take a look at this. This makes sense to me. What do you think? So I guess those would be the most important points that I would say is not say you have this, but this sort of resonates for me or makes sense to me. Would you take a look at it? And then hopefully from there, the person might be interested in the fact that there is treatment. Would that person see somebody or just have a consultation, or just have some way of just maybe having one meeting with somebody, not kind of saying the whole 10 yards you need to go into treatment, you need all this, but have that light touch.
So Maureen, one question I have for you on that topic. So one experience that I've had in clinical practice is kind of the difference between the statements of you're suffering, I've read about BPD and I think you might have BPD, those sorts of things, and the I statements. I know it's kind of cliche, but a lot of people don't always practice it. And I'm wondering what you think about the approach of simply encouraging family members to stick with I statements only, so that when their daughter or loved one calls them and says, oh my God, I'm in distress, oh my God, something's going on, oh my God, whatever, that the person simply says things like, I'm so sad, I'm so disheartened to hear that you're suffering still, and I wish I knew what to do, but I don't. But I think treaters might, or and then you plant the seeds in that way that I don't know how to help you, but I want to. I want to be of help, but I
Mm-hmm.
don't know how to help this anymore. You've
Yes.
called me numerous times, and
Mm-hmm. Mm-hmm. Well, I think it's a very important point, and sometimes I feel like, some of the tried and true things to remember are the simplest. So the I you statement is incredibly important. People with BPD have a lot of negativity. They have a very low self-esteem. They have a lot of difficulty feeling good about themselves. So anytime you say you, they automatically, their defenses are up, and it's a very ineffective. That's where communication skills come in. You statements are effective communication skills for everybody. So with somebody with BPD, and I find this a lot with family members, they just want to give advice. They want to tell the person what to do to make them feel better, that kind of thing. So what you're speaking about, Chris, is so important, which is saying, you know, it makes me so sad when you're this deeply upset, and I don't know what to do to help you. It's better to sort of say you feel unable to do it rather than you need to see a therapist and you need to do this or that or the other thing. They're going to shut off. So it's more effective to really speak to your experience. It makes me so sad, or it makes me feel so helpless to see how difficult things are. And I feel like, you know, some treatment could be helpful, or that talking to somebody who knows about this might be able to be helpful to you. So again, trying to not come down and tell somebody what to do, but to be authentic yourself about how difficult it is.
Great. So we've got a question on almost the opposite end of this spectrum. What do you do with a loved one with BPD who has decided to alienate herself from the family, disown the family, doesn't want help, yet people in the family are still terribly concerned and have reason to believe that she's not doing well? What do you recommend to family members? Should they keep reaching out, keep texting, give her the space she's asking for, and just leave her alone? Like, what should they do?
That's such a good question. My bias is to always keep reaching out in um, modulate it. If, especially you don't text every day, you don't do, but you invite people to family events, you try to keep things normal and find some way to stay in connection. There's a lot, this comes up a lot in my work where a parent will say, I text her all the time. She never texts me back or she never emails me back. And I'm just going to stop doing it. And then the patient is like, I can't believe my mother isn't even in touch with me, not taking any responsibility for the fact that this person has never acknowledged the text, but it means something. So I think, again, people with BPD are really struggling, feel very cut off and isolated, and even though they are the ones doing the cutting off, um, to remain available, again, without judgment, which is so hard to do, and I want to acknowledge how difficult it is. Um, but it's really critical to keep doing that outreach. Um, Family I work with, who may be listening, uh, said, we always invite our daughter for Thanksgiving. Should we invite our daughter for Thanksgiving this year? And the daughter is being very, doesn't want contact with them or speak with them or whatever. And I said, of course, you always invite her, so you invite her again. And that their need to stay feeling connected is a very important one. So even when you're not getting feedback in return, I would do that outreach, but I wouldn't do it too heavily. It's again that lighter touch, but consistently.
Okay. So, Maureen, the next question, we've had a few people ask about the labels and how important the label of borderline personality disorder or any of the other labels really are. And A couple of people feel that the labels may be harmful and not helpful. And so, how do you think about even the label of borderline personality disorder um, in terms of families being supportive of their loved one?
Mhm. Well, I feel like I'm saying this about every question. That's a great question, that, so I feel two ways about it. It is so valuable to identify a disorder like BPD. There is so much really terrific research being done on it. So a label, so to speak, is in terms of our clinical work is important to kind of identify the disorder and learn, about treatment and all of that. At the same time, I understand that there's a lot of misinformation and stigma still out there. I personally don't feel that patients need to, talk about their diagnosis or buy in so much. There are so many descriptive terms, and I know there's been, campaigns to change it to emotion dysregulation disorder or whatever. Still, any kind of a diagnosis can feel like a labeling, and that's always a negative thing for folks. People with BPD have such prominent features. They have high, emotion dysregulation. They have high reactivity. They have interpersonal hypersensitivity. I mean, there are so many ways to kind of say, let's forget the diagnosis. Let's just look at what the issues are that are most problematic for you. And what I like about the empirically based treatments, DBT, MBT, and whatever, they really target symptoms. So, it's most useful to think about, what is hardest for you? And if it's interpersonal relationships, then let's focus on that. Forget about a label. But you seem to have, when you have a kid who has a high reaction to relationships, when relationships fall apart and they fall apart, that there is an extreme reaction to these sorts of difficulties that we all have to sort of find ways to live through. So I don't think a label is important. It does really target treatment, so that's the only thing I would say. There's a usefulness to it, and then there are times when it isn't useful at all. But I think treating BPD is very important, and having specific treatments for it is important. And in terms of somebody admitting they have it or they don't, that doesn't really, that's not the important issue, I think.
Great. So another question that I've had come up clinically myself. What do you do when you've got an adult woman with BPD who blames somebody in the family for her issues and current situation, and she keeps bringing it up time and time again, despite numerous conversations around the issue and even thinking that you've finally settled the issue? What would you recommend for a parent in this situation? What can they say? How should they think about or handle the situation?
Well, it's again a very common situation, and we know this about borderline personality disorder, that there's often issues around anger. There's also a lot of issues around shame and feelings of worthlessness. So this dynamic of blaming parents or blaming family, it's often the parents, for you are the cause of my problem, is so common. And when people come into treatment, it's usually the patient saying, my parents should be hospitalized. It's not me, they're the problem. And in fact, it's so common that and as you noted, it's very hard for people to let go of. People who have a particular problem with anger, it is a kind of way to express anger, and it's often fueled by um, their own anger about not having a life or having life be difficult for them. People with BPD, life is not easy. Um, and we just had a case conference this week where we talked about somebody who has just come into treatment with a lot of rage and towards her parents and a total blaming. There's nothing wrong with me, it's all them. And, we struggle with this as clinicians all the time. And a very senior clinician was sort of saying, her approach was, well, that's not going to get us very far. Can we talk about, something that's going to help you build a life? And even if your parents got down on their knees and said, we did it all, it was all our fault, what are you going to do with that? How do we move on from there? So it's very challenging. People with BPD can get into a pattern of behavior, a pattern of blaming, and it's a way to deal with their own feelings, to displace it and put it on somebody else. So it's a very, believe it or not, it is a strategy that really works for them. It's not me, it's you. So I think it's something that parents, I often talk about parents, like, you can't have skin of Velcro. You have to have skin of Teflon. This stuff, you need to have it not deeply wound you all the time, but to kind of understand that it comes from this place of unbearable sort of negative feeling. But I think it also has to be constantly sort of addressed, like, what is this going to get you? How does this move you forward? So it's a very common.
So, Maureen, a couple of people have asked about the comment you just made, skin of Teflon. And a couple of people have asked, one person asks, how do you recommend people cope with verbal abuse that can come from a loved one with BPD when they're so angry? Another person says, I'm the spouse of someone with BPD, and it just increasingly is challenging, and divorce seems like the possible only answer. And are there coping strategies for loved ones to not take it so personally? It can be really difficult. And what are some strategies that can be helpful for loved ones?
Well, I just scrolled through the guidelines as you were talking because I have a few real favorites. So these are family guidelines that I'm going to refer to just now that you can download here. They are fabulous. John Gunderson and Cynthia Berkowitz wrote them maybe 18 years ago, and they actually are so common sense and basic, but they are embedded with DBT skills, mentalization skills, mindfulness. It's just sort of remarkable. But this first, what I'm gonna mention number 6, which is don't get defensive in the face of accusations and criticisms. However unfair, say little and don't fight. Allow yourself to be hurt and admit to whatever is true in the criticism. So let me preface this by saying I'm not saying that people should endure verbal abuse. So there's another there's another guideline I won't scroll to right now, but it's setting limits. You set limits based on your own limitations, and we'll get to that. But there is something about when you're being accused or criticized that is in this skill, which is very disarming. It's people are throwing, 95% of what they're saying to you is, off the chart and not true and hurtful and not in reality at all. But is there something about what they're saying that's just true? Well, I actually don't listen. When you start yelling, I realize I turn off and I'm not listening to you. I realize I do that. Whatever it is, it's also referred to as finding the nugget of gold in the bucket of sand. Is there something? It's very hard to do. It feels counterintuitive, but it can often de-escalate. If you start to defend yourself and no, that's not true, and I didn't do that, it is just going to get hotter and hotter, and it's not a strategy. Um, I know I've had parents who've locked themselves in the bathroom to get away from kind of an assault. And again, we're not talking physical, but you have to keep yourself safe. It is very, very hard. That idea that you listen, but you let it go by. You don't get snagged. People with BPD are tremendously, their sensitivity and their interpersonal hypersensitivity also makes them really good at knowing your Achilles heel or something that is particularly you're vulnerable to, and they can kind of snag you, and all of a sudden you're defending and fighting, and you're really you're lost in the conflict. So trying to set a limit, when you're talking to me like this, it's really hard for me to listen. Can we come back to this in half an hour? Or I'm feeling shut down, and it's very important to me for me to hear what you're saying. And I realize I can't hear it now because I'm too upset. Um, I just want to see if there's, as you can see, all of these are fabulous. So this is the setting limits, stating the limits of your tolerance. And this is also about being authentic. Let your expectations be known in clear, simple language. Everyone needs to know what's expected of them. But I do want to say, too, that something about language. People explain too much or talk too much. The simpler, the better. So setting a limit is just, this is what I can do right now. And if you can always connect that to, I really care about the fact that this is, that we get stuck here and I want to work this out. But right now, we're really not going in a positive direction. Can we come back to this at another point in time? Something like that.
Good. I guess I have a follow-up to that because as a clinician, I've treated a lot of patients with borderline personality disorder, and it's interesting to me how so many people can be stuck in the past and can want that almost excuse or rationalization for why their life is so difficult, and it's somehow because of abuse or neglect or something from a family member or a loved one or somebody unrelated. And and I often find I'm curious because as a clinician, I often find myself trying to bring them back to the present and saying to them, okay, I hear you loud and clear. You've had a difficult life. That was a horrible experience. That must have been horrific for you. But that was 10 years ago. And here we are today. And as your clinician, I want to help you get better now, today. And we can't rely on those people to do it for you. And getting an apology from them isn't necessarily going to do anything either way. Like, even if they did apologize, how is that going to help you function today? How is that going to help you keep a job and not injure yourself and not be so suicidally depressed, or whatever struggles they're having? And I guess I'm wondering if you think family members have a role in something similar, or if that is really better left to the clinician. It's easier for me because I'm not the one who supposedly was the perpetrator, but yet I find it so helpful to continually orient them to the present and the future because that's all we really get in life. We could all live our lives in the past and just wither up in a ball in a room and never move forward. But really, the present, I guess, is all we really have. And so I find it very useful to continually bring them back to the present and say, okay, can you help me understand how that story or how that horrible situation is impacting your safety today or is impacting your inability to keep a job today? But I don't know. I'm curious as to your thoughts. Do family members have any role in that?
So the couple of things come to mind. One is I just want to underscore what you're doing as a clinician, and it makes me think of mentalization. Sort of like how does this help you? How does this help you understand your experience? I mean, so trying to understand what the purpose of keeping that, that old mantra, it was this or that or the other thing, and I do see this a lot, that. People come into treatment and they're angry at their parents, something their parents did when they were 12 and they're 30, and the parents have apologized and that sort of thing a million times, and it's still, oh, they didn't mean it, that kind of thing. One thought in terms of what families can do, because I think these are very complicated things, as you're noting, as a clinician, it's very challenging, and understanding the meaning of it and helping people let go of it. people with BPD have a lot of avoidance strategies, and this is an avoidance strategy in my mind about kind of it does. You're stuck in the past, and it's a way that you don't move into the present and the future, which is very scary. So I think a clinician would deal with it in one way. What I have to say about this is I think family therapy is not a first line of treatment with people with BPD. You have to have people have to be skilled. There has to be some some work done in preparation. But there's a lot of power with a family being involved in treatment in some way and having some family meetings around how to find a way to let it go. What does the patient need from the family besides, I'm sorry. And sometimes it's like, I want to understand better what that was about and an opening to exploring it and looking at it. I say that with great caution because there are some things that don't really, family therapy again is something that's not available to a lot of people, and I think everyone has to be in a very skillful place to actually do it. But I think this also goes to families being educated and skillful themselves. They're learning how to respond in that situation. To say, it makes me so sad to see that that is still something you're so angry about, and I wish I knew a way to help you with that. Again, it's the I statement, and some recognition that way. But I think it's challenging, and you need to keep finding ways to
Great,
address it.
thank you. A couple of people have asked a similar question. How do how do you handle situations where the family members, especially maybe from a divorced home, don't agree on the right treatment approach? Tough love versus enabler, for instance. Another person asked, what do you do when your daughter with BPD is married to a spouse now who's pretty controlling and doesn't think she should get any therapy at all? Um, so I guess the overarching question is when other people in the family, either her own new family or your existing family, disagree on treatment approach, treatment strategies, any any helpful suggestions or thoughts about how they might handle that?
Well, what I do want to say, particularly around parents and very particularly around divorced parents, and even more particularly divorced parents who are still angry at each other, is that somebody with borderline personality disorder really brings out a polarization with parents because I think one of the people wrote in said enabler versus limiter. So usually there's one parent that becomes like the cop, and the other parent that becomes like the nurturing, uh, you know. Very sympathetic one. So this happens for parents in general, and it happens in extreme ways with people with BPD who have extreme reactions to this. So um, the idea that as parents together, you find a way to sort of look at that. Right now, we just have one multiple family group, but I have done many of them over the years, and the most, I think, important ones that I had were all couples. They were all parents, and they would come in and they would all be fighting with each other that you didn't do it right and you didn't do it right. And everybody could really empathize with how challenging it is to go to that middle ground and have a common shared perspective. And I think there are ways in which having two perspectives on how to sort of be there for a person is useful. You don't always both have to be exactly in the same place because we're all different. And, as parents, we often see our children in different ways. So um, some of it is just unavoidable. If you and your spouse, I'm just going to do the spouse part now, if you as parents can agree on some common goals, and also that I know John has written about this, and it's also in some of the family guidelines, is that you can kind of take turns being the tough one, and the other one can be the, oh boy, that's so hard, that you have a curfew or whatever it is, but that you switch off, and the person that the parent who is more sympathetic becomes the limit setter, and the one, so that you, because parents don't always, the person who's the limit setter doesn't always like being the cop. They may want to be the one that's saying, oh, I see how difficult this is, and that's really tough. And the other one saying, yeah, and we're not going to give you any more money, or whatever the issue is. Um, so using things like the Connections program, getting educated yourself, knowing the importance of not being split as parents, the tremendous problems that arise when parents disagree about what to do with the kid, and I'm saying kid, young adult, uh, it's, um, it's very problematic. The issue of the woman whose daughter married and has a controlling husband, that's a very tough one, because then you're not only the mother-in-law, but it's also your daughter is in a relationship with somebody. And I think what I would do is just stay open to the daughter and keep communication open. Ask her, just say, sometimes I wonder if this isn't hard or whatever. Somehow opening up the conversation, but being careful. Sometimes people with BPD get in relationships that families are very concerned about. It's always the bad boyfriend or that kind of thing. So if you come down too strong on that, it will backfire. So again, I think just keeping open to your daughter feeling able to talk with you about this, and have you not have too much of an opinion, but to really actively listen to where she's at.
Great, thanks. A few people have asked about the topic of siblings. So these are parents with a daughter with BPD, but they have other children. And I've read about a few different scenarios. One is my daughter with BPD makes family celebrations full of drama and gets people upset. And what should we do? Should we continue to have those? How do we think about it? Should we just not include her anymore? Should we cancel them altogether? Another person says that her siblings are really starting to hate her. And what should we as parents do? And how should we talk with those other siblings about this? And then another one has a different twist, which is my daughter with BPD has such poor self-esteem, hates herself, sees the other siblings as perfect, and so is distancing herself from them because they're so perfect and they're impossible standards to measure up to. Yet this mother feels like someday we're going to be gone and those siblings are going to be all she's got, and we really want her to maintain those connections.
These are very poignant examples and ones I hear every day, and it seems to me that one of the things that parents deeply value is their children sort of connecting and loving each other. And when you have someone with BPD, they're often, in the kind of turmoil that causes family turmoil that can actually make their siblings be furious with them because they're ruining celebrations, they're causing the parents lots of heartache and angst, and then there's a lot of attention given to the person with BPD. So it is really a recipe for a lot of sibling feelings about this. And you often sometimes get siblings who are really terrific and just really are the good kid and keep quiet. And I've had lots of situations where the siblings come back years later and say, I'm really angry because I didn't get the attention, and I was really behaved well. So, there's siblings don't have the same kind of sense of responsibility towards their sibling as parents do to their kids. So it's a different level of kind of commitment. Um, so I think you can't, you just need to support the other sibling and give them the room they need, because saying you just have to put up with this is really not the way to go either. I want to go back to the family celebrations, which I touched on a little bit when we first started. I do want to say that when you know that family celebrations, and we're coming on Christmas, and these, we just got through Thanksgiving, which was hard enough. that you really talk to the family member with BPD and and say, I know these things are hard because they're often torn. They want to be part of the family, but they have many, many issues that come up around the holidays. And there's so many, I can't even begin to think of them, but it's often something that was just mentioned, I'm going to be the only loser in the room. My siblings, my cousins, everyone's like getting married, everything's so fabulous, and here I am, I dropped out of school and I'm in treatment and I'm a loser. So celebrations often bring up this sense of identity or this problem with who they are and feeling of self-worth. So they're really, but yet they want to feel connected to the family. So a strategy of kind of saying, okay, come, you can stay for 5 minutes, you can stay in your room, you can come down here, try to work with the person with BPD about making it manageable and acknowledging that both are true. They want to be part of it, or they may be saying, I'm not coming, I would never come, and I hate my family, I hate everybody, why would I ever do it? And say, well, we hope you can stop by, hope you can come down, whatever it is. Again, always extending that invitation and saying, and I know it's really hard for you. So the whole family system, I think there are three excellent questions, and they're it's such part of the burden that families really struggle with is, the parents say, we're going to be gone, and then they're going to have to take care of them. It's a different sense of responsibility, and I don't really have an answer for that, except you cannot force this on your other kids. You have to really be open. There are a lot of kids who say, I do not want my brother or sister in my life. They cause chaos. That's it. And other ones who kind of can hang in there, and that's very individual.
Great. So, kind of a global question. How do you think about or differentiate um, being supportive of a child with BPD versus enabling?
Yeah, that's such a good one. Um, it's often examples are often the best way to do this, but I think when you start questioning, I'm doing too much, you really want to take a look at that. And I'm really cautious about it because people with BPD are so needy, and they really do require a lot of support. It is quite a burden. But when you're giving them too much money or too much of your time, if you're when I hear people, oh, well, I'm on the phone with her like 3 or 4 times a day, I'm like, no, you've got to stop that. This is where the family guidelines are very much a kind of a touchstone. You really want to have certain expectations. I could talk to you 1 time a day. One of my best examples is a mother whose daughter was incredibly needy, um, called her multiple times a day about everything. Where she was worried about this, didn't know how to do this, and she was somebody who was on call all the time, so always answered the phone. And it was just, she was like, I can't, I'm so worn out, but I'm afraid if I don't answer the phone, blah, then she calls me 10 times. So the strategy was setting up a time to go have uh, a special lunch with her on the weekend. The mother first said, I don't want any more time with her. I actually want some space. But the strategy was to be there for her at a time when the mother could do it and was available and could be there 100% for her. And then cut back, say, I can check in with you every night at 7 or something like that. So you want to be supportive, but you don't, when you realize your limits are being pushed, or that you can see that it's too much for you, that you try to recalibrate. And it's ideally to do that collaboratively, to say, this isn't working for me to get a lot of emergency calls during the day, but I want to be supportive and help you. So how can we do this so it works for me and works for you?
Great. Um, One last question, and I'll ask it because a couple of people have asked about it, is the the overlap between borderline personality disorder and people who have a lot of physical symptoms, sometimes called hypochondriasis, somatic complaints. But, one person talks about the fact that her daughter is in emergency rooms almost every week. Another person needs to see the primary care doctor all the time. And how should that be managed? What's the family member's role, and what if any guidelines would you recommend for treaters in terms of managing those types of symptoms?
Well, this is very common. I just lost my screen. I don't know if that matters.
No, we see you. We see you still.
Okay, all right. I'm looking at MacBook Pro, but the so it's very common. If you think about people with BPD have a lot of hypersensitivity, you often see people who have that sort of physical hypersensitivity. So you often see people struggle with migraines, PMS, fibromyalgia, chronic pain, all of these things too, and some to an extreme that they're always going to the doctor. So there are some people who have a subset of this that becomes quite problematic. And that's where, at McLean we're doing, there's a number of people in our program who are doing outreach for primary care clinicians to try to help them kind of help manage people with BPD who can be very seeking of medical treatment. So I think what I've worked with families a lot, when I need to go to the ER because of my stomach ache at 2 in the morning, this is where you set your limit. And, it's a hard thing without a specific case to do, but you want to not promote seeking of medical services when you're clear on some level that it's for attention, it's for solace, it's for some kind of sort of displaced need to, way of getting comfort. So I think it's a very important one, and yet I had worked with a family who had a daughter just, like this, and they were always, she needed to go to the doctor all the time. And then, of course, the one day she wants to go to the ER, she has a gallbladder, attack, and she had her gallbladder out. So, it's very hard for families. You're not medical professionals. You don't have to make judgments on it, but you can limit how much you are interested in it, how much you take somebody to the doctor, to the ER, and make sure they have good primary care, and you can, ideally let the primary care person also know that the person, that your family member also has some emotional issues. It's very, very common.
Great. Thank you so much, Maureen. Thank you all for attending. It is past 5 o'clock, so we are going to.
Can you go to the last slide to make sure that people see the
Yes.
resources? I can't see the slides. Oh, there we go.
Oh, you've got it?
There you go.
Okay.
I just want to make sure, and a big plug here, that's NEA BPD, the Connections program, which you sign up for on the NEA BPD website. It's free 12-week class that are run by parents who are trained, and you can do it on the phone and in person. It's really fabulous. It's DBT based, and it's something that they're really trying to make accessible to people around the country. So I just want to underscore that. And the BPD Resource Center, the second one, they do give referrals of people who treat BPD, and that's you want treaters who understand this diagnosis. And I didn't realize they had that till I met the people who started it, and they have a whole referral network, so want to make sure people know about that as well.
So great. Thank you so much for those resources. And again, if you want to download those resources, you can download everything that we've talked about at the bottom of your screen on the left-hand side. If you just click on those PDF documents, you'll be able to download everything to your own computer and come back to the slides, come back to the family resources, this resource slide. And again, you can come to our website at the very left top of the screen. If you haven't bookmarked our page, please do so. And we hope that you'll join us for our January webinar with Dr. John Gunderson. Good night, everyone.
Good night. I felt like this